Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Discharge Planning and Aftercare Best Practices with Gabriela Zapata-Alma. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel as well. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will first need to register or sign into your account to complete the evaluation. Information you provide FADA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close midnight on Wednesday, February 24th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license numbers for reporting to CE Broker. If you are certified with the Florida Certification Board or licensed outside of state of Florida, you do not need to provide your certificate number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Gabriela Zapata-Alma is the Director of Policy and Practice for Domestic Violence and Substance Use at the National Center of Domestic Violence, Trauma, and Mental Health, as well as the faculty at University of Chicago, where they coordinate Advanced Alcohol and Other Drug Counselor Certificate Program at the School of Social Services Administration. Gabriela brings over 15 years of experience supporting people impacted by substance use disorders, mental health conditions, violence, trauma, housing instability, and HIV and AIDS. She leads a program using trauma-informed approaches, motivational interviewing, harm reduction, gender-responsive care, housing first, and third wave behavioral interventions. Gabriela has been recognized with numerous awards, including Health and Medicine Policy Research Group 2018 Health Award and the 2017 Rising Star Award from the Illinois chapter of the National Association for Addiction Professionals. Gabriela provides consultations on trauma-informed policy at the national level, as well as training and technical assistance related to serving marginalized communities impacted by trauma and other social determinants of health nationally and internationally. And now I'd like to welcome our presenter, Gabriela.
Thank you so much for this warm welcome. I'm so glad to be here with y'all this morning to share this information. We know that when folks are completing services with us, that this is such an incredibly important time to be supporting folks as they really seek to apply some of the things that they have been gaining throughout services with us in kind of their continuing experience. And so there's so much that we can do to support folks to really engaging in that long-term health and well-being. So I'm going to talk today about some of the evidence-based practices as well as some promising practices, and always keeping in mind that what the trauma-informed approaches look like, because we know that there is such an incredible link between trauma and experiencing harms related to substance use. So, and thank you so much for sharing a little bit about me with everyone. One update I have is that I'm now the Associate Director of the National Center on Domestic Violence, Trauma, and Mental Health. And our center is a special issue resource center dedicated to the intersection of domestic violence, trauma, substance use, and mental health. And so here you see our integrated framework. Everything that we do is rooted in survivor-defined approaches. What that means is that people are the expert on their own experience and know what will or won't work for them, or what's possible at this time, what's safe for them at this time. That everything we do is rooted in relationship and connection, especially when people have experienced harm in relationship. Healing is based in relationship. We also know that recovery is based in relationship and in community, right? So everything we do really is seated within that relational approach. That a sense of physical and emotional safety is paramount, and that safety is self-defined, right? It's not for somebody else to say, what makes somebody feel safe or not. And that our services ultimately need to foster hope and resilience, that there is no recovery or healing that is born out of shame or judgment or othering, that everything is through connection and hope. And so with that at our core, we then integrate the frameworks of domestic violence and sexual violence advocacy. For folks who aren't familiar with that, that can also be understood as an empowerment framework. We integrate that with trauma-informed approaches, with human rights and social justice-based approaches, and approaches that have an awareness of and responsiveness to cultural, historical, and community context. There is no one size fits all, right? And we'll be talking about that more as we talk about discharge planning and aftercare. So here are key learning objectives. I imagine you already looked through these as you signed up for this session. So we're going to launch our first poll, and we'd love to hear from y'all. What is your current setting? And if your setting isn't in the poll, feel free to go ahead and click other, and then in the chat, share with us what your current setting is. So Rebecca, if I could have your help with launching that poll. Thanks so much. All right, about 10 more seconds to make your selection, and then be sure to hit submit once you make your selection. I'm just waiting for the results to be displayed. Here we are. So we have most folks in an other, so I look forward to seeing in the chat what your setting is. And then after that, most folks in an outpatient substance use disorder treatment setting, followed by residential treatment. And then we have folks from recovery community organizations. Awesome. And then a couple folks from recovery housing and inpatient withdrawal management. Thanks so much, folks. And then looking over here at the chat, we see a runaway shelter and substance use treatment program for adolescents. Yes, so important. So feel free to continue putting in the chat, what are the different settings you're working in? And one of the reasons that we start by asking that is because while there are many things that are shared across settings, there are some specific particular risks and discharge planning and aftercare needs that are unique to certain settings. And then we see folks in private practice too. Thank you. So first, recognizing the continuum of care as defined by the American Society of Addiction Medicine, that as a field, we are looking to move beyond solely acute care models. So, gone are the days of, having kind of only crisis focused or only very, high acute focused models of care. And what we want to focus more and more on now is that full continuum of care with, people may enter at any point in this continuum. So don't necessarily need to start with residential, may enter directly into outpatient, offering withdrawal management services at every point in the continuum. But then also, as people enter at higher levels of care, or maybe enter at a lower one and end up needing a higher level of care, making sure that we are doing everything to support that step down, that folks have that continuing ongoing support in those lower levels of care. And if not through those lower levels of care, then absolutely through connecting folks with resources in the community and through offering our own accessible aftercare services. So this is part of the whole movement to move beyond the acute care model, because we know that very often needs related to recovery and substance use are not something that, are one and done. It's not a checklist that we just run down. It's something that really reconnection with community and having more of that long-term support is incredibly instrumental. And one thing I'll say is that peer-based recovery support, recovery community organizations are vital resources and collaborators at every part of this continuum. So I mentioned that because sometimes I've gotten the question of, well, where does recovery support fit in here? It fits in everywhere, including outside of the continuum of care for folks who either don't meet criteria for formal treatment services yet, or at this point don't have access or aren't interested in formal treatment yet. And now I want to hear from y'all. Why do you think that discharge planning and aftercare are especially important at those higher levels of care, looking at more of the, the medically managed and medically monitored inpatient settings, as well as residential treatment? Why would aftercare and discharge planning be especially important in those settings? And I'll give y'all some time to put your responses in the chat. To prevent relapse and reoccurring problems, to maintain stability, to make sure folks don't relapse or go back to old behaviors. They have the support to continue their progress, higher levels of success. Yes, the person needs a guidance plan to be able to successfully transition to a new form of living. Yes, to prevent readmissions. Because people need wraparound and holistic supports. They're so often sent out into the world as, quote, cured, but the need continues and there's a need for follow-up. Absolutely. To make sure that stability continues after the higher level of care, setting them up for success, to support that improvement in overall functioning, to maintain healthy recovery. Yes, treatment continues after inpatient. Yes, the goal to help them be successful in their recovery. Yeah, we certainly don't want to be setting folks out and setting them up for failure, not by any means. It supports folks with their motivation for ongoing treatment and recovery. The risk of relapse and readmission is greater at higher levels of care. Yes. Folks don't always have a support system. We are their support to ensure a safe transition. Yes, there is so much of this that we have to consider about core safety needs. Absolutely. Thanks so much, folks. Keep those responses coming. And then, I have a couple data points here that I'll share as well. So from some of the available research, there was one study that continued to follow up with 448 people over the course of 2 years. And what they found was that about 1/3 of the participants often transitioned from being either in recovery to needing treatment, or from being in treatment to the community, right? That there was a lot of transition within that 2-year period in where people were in their recovery journey, right? So 82% of those participants transitioned at least once in that 2-year period. And then 62%, so 2/3, transitioned where they were in their recovery journey at least 2 times, right? And that is a study done by Scott and al. Also been found that connection with ongoing community-based recovery support is associated with better recovery outcomes, and that aftercare services have been found to support recovery maintenance. And we'll talk more about what that can look like. And then there's also been research done by Fiorentine and Hillhouse in 2000 that found that people who had both treatment and recovery support groups had better long-term recovery outcomes than people who just had access to one of those services. So this is where, again, that collaboration and offering of, different kinds of resources is so incredibly important. So, who's involved in discharge planning? So first and foremost, the person accessing the service, the person whose life it is. I can't tell you the number of times that someone accessed a higher level of care from our intensive outpatient or outpatient program. And then, we were trying to follow up and collaborate and have some communication, and we had trouble getting really any response from that higher level of care during that short time that that person was there. And then the person, appears back at our program, thankfully made it back to our program. We didn't know that they were finishing at the higher level of care, thankfully makes it back to our program. And then the discharge plan that they show us was done without their participation. And there's so many problems there, right? Especially when we consider people are the expert on their own experience. People have so many strengths and resources that can be that we really want to be building on in any kind of discharge planning. And then, of course, the discharge plan needs to also be able to assess for any potential gaps or threats to recovery and how to appropriately plan for those in a way that is collaborative, person-centered, and really supports the person's self-defined needs and goals. Absolutely. Here I see in the chat to me, all services should be client-driven. Yes, 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 yes. Absolutely. I remember a time where our program didn't have a psychiatrist on the team yet. We were hoping to add one, but we didn't have a psychiatrist yet. And the discharge plan said, continue psychotropic medication with your program psychiatrist. Wow. A simple conversation with the person and with us would have clarified that that wasn't realistic at that time, right? And that we could have worked together to identify a community resource to continue access to that service, right? So absolutely the person accessing the service. Then we want to be sure that we're not just taking a solely individualistic approach, that we are asking that person, who are their safe social supports and how would you like them involved in your overall services with us, including your post-treatment planning. That's another way that we talk about discharge planning as well, post-treatment planning. That, time and time again, research has shown that when people have the support of their significant loved ones, their significant others, their significant social supports, that those recovery outcomes are so much more improved, right? We are relational people, we are relational creatures. And so when we can have the support and involvement of the people who we name as being important and safe, then that can really improve our overall well-being and recovery outcomes. A care team. So here, really talking about an interdisciplinary team that can include direct service staff, such as treatment providers, recovery support whenever we have recovery support embedded within our team. And this is especially important to have peer-based support specialists. I can tell you, as a treatment provider, when we were able to piece together some funding and be able to have dedicated peer-based support specialists, that improved the effectiveness of our programs. Just, 200%. It was so much more effective and meaningful for people, so much so that we actually then were able to cultivate funding to have whole teams that were wholly recovery support specialists who are peer-based, right? This is incredibly, incredibly important in any setting that we're in. And if we don't have folks within our team, then of course, always looking to collaborate. And then an emerging practice is actually to have a dedicated discharge planner, a person whose specific role is to discharge plan. Now here, there can be a pitfall potentially, because what we don't want to have happen is that the only person who talks about discharge planning is a discharge planner, or that the discharge planner is introduced at the very end of the service, and now the person has, frankly, a stranger that they're supposed to be discharge planning with. So if there's going to be a dedicated discharge planner, then we want to be sure that that person is connected early for many reasons. First of all, that lack of relationship, we don't want that to be a barrier to discharge planning. And also because it's important to start early in our discharge planning. And I'll say a little more about that actually in just a few seconds. But before I go to the next slide, I also want to mention that an emerging practice is to offer a discharge planning group as part of the groups that are offered. That so often it can be hard to anticipate what life after this service looks like, or what some of my recovery needs might be once I'm no longer kind of accessing this service in this frequent or structured of a way. And so having that group and that peer-based support within that group around people discharging to planning their discharge together can really help with the brainstorming and people sharing resources and ideas and building up that motivation for what life after this service will look like. So, how can we as practitioners, and when I say practitioners, that is inclusive of treatment providers, peer support providers, right? Kind of anyone who is in a position to support folks with this process. So how can practitioners support recovery through discharge planning? First and foremost, we need to start early. This needs to be a conversation that begins at the very beginning, right? So we can often open up this conversation with, as we are treatment planning, at the very beginning, asking folks, how will we know when this level of care, or how will we know when either treatment or this level of care or this service that you're accessing is complete, right? What will be some of those signs that you're moving towards that readiness, right? That you're meeting your goals. And then those signs are collaboratively identified, and they're mutually understandable. So they aren't in kind of in a language that people don't identify with or can't, that doesn't really speak to their self-defined goals or needs, right? So it needs to be collaborative, needs to be mutually understandable. And then we can also talk about, right, what are the data sources? How would we know, right? So some different potential data sources might be as people complete some of their self-defined treatment goals. Or are we looking for some symptom reduction or symptom management? Is it based on the person's self-assessment, on staff observations? Are you using standardized measures, right, to measure any of this? In a treatment setting, it may also be likely that you may use something like some of the holistic multidimensional assessment as defined by the American Society for Addiction Medicine, right? Where treatment is no longer medically necessary based on that reassessment criteria. But most importantly, we want to have these conversations early on as much as someone is able to engage them. We don't need to overwhelm people with the conversation, but to start planting those seeds as much as the person is able to engage it in that moment. And then, when we do this, it supports that transparency, that consistency, and that predictability, that we have a roadmap that we have built together. And so there aren't any kind of big surprises where we're now saying, okay, you're done, right? But that it's something that we're talking about in an ongoing basis. And that this really supports that autonomy within our services as well. And all of this are essential aspects of trauma-informed approaches. Then we're individualizing a written plan. So we want the plan to be not only collaboratively discussed, but also written in a way that is mutually understandable, that is accessible for people. And so that, accessibility can be language accessibility, it can be, and then obviously if there are not, that it's written in a way that meets kind of the literacy level, and then if there isn't literacy, that it's communicated in a way and talked about frequently in a way that feels supportive for the person. That doesn't feel like it's like, oh no, here we go again, I'm being told the same thing. When we individualize it, it's really important that we aren't just using a cookie cutter approach. It's not going to work here, like in most things that have to do with recovery. So we want to be identifying those needed resources and facilitating access to those potential community resources and partners early on in the process. So if we are, for example, Sharing information about different kinds of community-based mutual aid recovery groups, that we are offering a diversity of information on the different kinds of groups that exist, because different people connect with different groups, right? And there are some times that someone might not connect with a group at all, or connecting with a group might not feel safe or be safe in that moment, particularly for survivors of interpersonal trauma, of gender-based violence, right? So we would never force connection with a community mutual aid group. And frankly, that would contradict what's magical about mutual aid, that it's voluntary, right? But we do want to be sharing that information early on and then cultivating opportunities for people to safely try these out well before the end of the service with us, right? And then we want to continuously be reviewing and updating this plan as needs change, evolve, emerge. The needs that are there at the beginning of a treatment episode are often very different than the needs that are evolving and emerging as treatment goes on. And that's part of the point, right? Is to see that change. And then, of course, throughout care and aftercare, we want to be nurturing those recovery management skills and community reintegration. So along those lines, that continuing recovery planning, it dynamically flows from treatment planning. So really, discharge planning is kind of like the continuation of that treatment planning and extending it post that specific treatment episode. And so some of the main goals of continuing recovery planning are things like maintaining treatment needs, including things like crisis prevention and management and planning for potential setbacks in those recovery goals. And here, for folks who may have co-occurring substance use and mental health needs, WRAP, which stands for Wellness Recovery Action Planning, can be a great evidence-based practice that is peer-based, right? Here, we're also looking at things like supporting greater life goals, recovery capital, always, always, always. Cultivating both internal and external access to recovery capital resources, and aftercare planning, which we'll talk more about aftercare services in a little bit. Here, incredibly important, right, to cultivate and actively connect to diverse community resources. We really need to move away from any one size fits all. We need to move away from prescribing what is going to work for somebody. That is not effective. And it's especially not effective for people of diverse, gender backgrounds, racial and ethnic backgrounds, diverse socioeconomic status, right? Just the broad diversity of humanity. There is no one size fits all. Just like there are many paths of recovery. So withdrawal management services and substance use disorder resources, I want to share some data here because when it comes to discharge planning, there is a particular risk around withdrawal management. As we heard earlier, as people shared, why discharge planning and aftercare is particularly important at those higher levels of care. So there has been research that has found that around 80% of people who access a hospital-based withdrawal management service, which is also sometimes called detox, don't have access to substance use disorder services while there. So they're only getting the physical withdrawal management and not having access to any of the other holistic wraparound services. And then 85% of people who access withdrawal management through an emergency room do not access substance use disorder care post-discharge, right? Don't have access to kind of ongoing services there. And then withdrawal management alone for opioids without stabilization and on medication-assisted treatment and recovery, and really that warm handoff, that linkage to ongoing continuous medication-assisted treatment and recovery, that has actually been found to increase the risk of accidental fatal overdose. And we can see why, right? Because we know how incredibly life-saving medications like methadone, Suboxone, buprenorphine, etc., how incredibly life-saving these medications are in the context of opioid use disorder, and that without that linkage there, the craving continues, there can be some low-level withdrawal that continues, and then the person doesn't have access, and their tolerance has been lowered. So then without the access, without the access to MAT or MAR, and paired with no tolerance and continuing craving, then this is a recipe for disaster, right? So this really raises the ethical concerns of withdrawal management services without the appropriate stabilization on medication-assisted treatment in the context of opioid use disorder, particularly. So I want to briefly share just a story. And so, of course, this story does not contain any identifying. It's been it's protecting people's confidentiality. So it's a combination of kind of multiple people's experience. So Fred, which of course is not a real name, but let's talk about Fred. So Fred was using heroin and had accessed withdrawal management only services at his local hospital when he wasn't able to access any kind of opioid use disorder care. And, he was in the hospital for a few days, and there was no discharge planning or aftercare. On his last day, he was given a list of methadone providers in the area, and that was it. That was all that happened in terms of discharge planning or aftercare. And so when he started calling all places on the list, and none of them took his insurance except for one. And the one that took his insurance didn't have an intake available for over 30 days. So he'd been in detox for 3 days, and then now was facing a reality of he could not access any kind of service to deal with his ongoing need for over a month. So unsurprisingly, he began using the next day after feeling very, very hopeless in his search to find ongoing treatment. And it's the reality that when we are trying so hard to access the resources we need and they're just not there for us, that we feel hopeless. We feel like, why even bother, right? And we know that recovery is born out of hope. So unsurprisingly, he began using again the next day. And this was before the age of fentanyl poisoning the drug supply. So he did not, thankfully, experience an overdose in that moment, which in this day and age, the risk of experiencing an overdose in that initial use is just sky high. But what did happen is that he was drug tested by his parole officer and experienced a parole violation and returned to prison. So discharge planning and aftercare support are not only critical for supporting long-term recovery outcomes, but they're also essential for preventing life-altering outcomes, including incarceration and even death. And this story also tells us something about the need, right? Here's a person who's trying so desperately to do something different. And then when they test positive, they are punished again rather than having access to the resource that he has been working so hard to try to access. And so it really tells us the importance, highlights the importance of, in all of our services, having, in all of our systems, I should say, having that orientation towards support and access and not punishment. Recovery is not born out of punishment. And I see here in the chat, we need more peer mentors in the hospitals. Yes, 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 yes. I will sing that to the rooftops all day long. Absolutely. So, withdrawal management services, what can help? Recovery and peer-based support specialist, essential for bridging this gap, especially because not everyone who accesses a withdrawal management service is, decided that they want to attend a formal treatment. So one of the really, really beautiful things about recovery and peer-based support is how incredibly person-centered this is, and how these folks are able to offer support whether or not somebody has decided that they want to engage in treatment at this time or they're ready to engage in treatment. Overdose prevention education, direct access to naloxone. All of us should be distributing naloxone, and safer use resources, the full continuum of safer use resources. Buprenorphine induction. So having withdrawal management that will include buprenorphine induction, buprenorphine being, also Suboxone is the brand name for the combination of buprenorphine and naloxone. So having buprenorphine induction in some kind of way, whether it's Suboxone or another form of buprenorphine, and then making sure that people have enough of a prescription to make it to an ongoing MAT or MAR provider. Too often, as a treatment provider, I can't tell you the number of heartbreaking phone calls I received saying, I was discharged. I only have 2 more days of my Suboxone prescription. I need to get into treatment right now. And it just wasn't realistic that we could get them through our intake and seeing our prescriber within those 2 days or that day and a half by that point, right? Or if they had already called all these different providers and then finally gotten to us at the bottom of the list, maybe it was 1 day or same day access that they needed. Our substance use disorder treatment system absolutely should be striving for same day access and I mean, that's truly what's needed for the current overdose epidemic. That is what's needed, but it's not typically the reality. And so we need to make sure that in bridging the gap, there is that sufficient prescription, while also creating low threshold MAT access. And there are a lot of promising practices and evidence-based practices that include bridge clinics. So a clinic where people can walk into and continue accessing MAT until they're able to make it through the intake in an opioid treatment center or in a office-based buprenorphine provider, as well as mobile MAT. Something that we have really learned throughout this pandemic is how incredibly important it is for our services to be able to go into the community and really reduce so much of the barriers that people experience. Warm linkages, meaning that people are actually connected and that one service doesn't stop until the other service really has them within their program. And then seamless care coordination across settings. So here, really talking about that the service of that care coordination follows the person across settings, not that, there's one person in one program who says, here's your list, and then there's, the person doesn't have anyone helping them with this until they make it into the next program, right? That creates huge gaps in our what's often very siloed services. And this is where recovery community organizations and peer-based recovery support can be also an incredibly important and unique resource in that seamless care support across settings so that that support follows the person. And then I see here in the chat, thank you so much, talking about Fred's situation in the previous slide, that Fred could also contact parole services for help to get into treatment. Yes, and that speaks to exactly what I was trying to say before around, if somebody is on parole or probation, that we need to have that built into that system, the ability to access that support without fear of just not getting that resource and going directly, being punished in some way, going directly back to jail or prison, right? All right, so successful transitions. And I'm going to focus I'm focusing specifically on this just because there is such, oh my goodness, so we're in an overdose epidemic. We're seeing unprecedented lives lost to accidental fatal overdose. And so this successful transition to this life-saving resource is just, it couldn't be more important, right? So here, having strong linkages with MAT providers, with community-based providers. So we need to be cultivating these relationships and these resources in advance. Our staff have to have a thorough knowledge of the requirements for linking to partners. And then, does their intake process align with our discharge process, right? Sometimes there's a challenge there, right? If intakes can only be done in person, but we don't, people are on our floor until they leave and they can't go attend in person. That's a barrier. And that is a barrier that is created by a system, right? It's not a barrier that is naturally occurring. So understanding both the services that are offered and then how to access them and building those relationships are necessary components of being able to have well-coordinated and gradual transitions so that people don't end up slipping through the gaps. Because that's what ends up happening too often. And that part of how we can ensure that well-coordinated and gradual transition is having some collaborative aftercare planning together. So inviting that new community partner, of course, if the person whose aftercare plan it is open to that, if they're in agreement with that, but including that community-based MAT provider in that process. So the MAT provider can be on the same page, can help inform it, and can help contribute to the plan, right? So then we know, okay, they'll be able to see our prescriber and be assured access MAT by Thursday, and today's Monday. Okay, great. So then we know that this person needs to have a script to get them at least a Thursday, and then let's stay in communication in case, for whatever reason, there's a hiccup in the plan, and we can make sure that there's ongoing seamless access to MAT. So there are no gaps. Sometimes the gap can be something that is outside of our control. Like I remember when I had folks who had Medicare in my treatment program, and there would be times that it really seemed like out of nowhere, all of a sudden, Medicare was requiring the pharmacist would let us know that Medicare was requiring all of this extra paperwork, and for our prescriber to fill out and sign off on before they could dispense the medication. And so, sometimes that would take more than a day to pull together, even though we were doing our best to pull it together as quickly as possible. So then, even better, to have, that buffer there, because there can be things that come up without our being able to anticipate it, right? If it's the last appointment of the day and now we're hearing that the pharmacy can't dispense it, then that's going to be a gap for that person if we haven't been able to anticipate and plan for it. And then, if there is a need at any point for a higher level of care, then being able to re-engage in that higher level of care before we're in crisis, and in a way that is that is intentional and is done with planning and with the person, of course, at the center of that, really driving those decisions. So, of course, all of this will require things like written informed consent, to release of information, in order to actively coordinate the transitions. And if the person, for whatever reason, lets us know that no, they don't want that, part of informed consent is us, um, supporting folks by just offering information on what are some of the risks and what are some of the benefits, to aftercare planning, discharge planning, so that they can just make an informed decision. And ultimately, it is their decision. But we want to be prepared to have, to offer best practices and then support people in this way. So here, I want to be sure to highlight a resource that y'all have in Florida. It is so amazing. I Save Florida Overdose Prevention. And folks can access naloxone through the website, and it will be directly mailed. I believe there's also a phone number. You can also become a naloxone distribution site, which, as a provider, we became a naloxone distribution site, and that was such a huge, huge step for us in saving lives. And then, of course, getting trained on naloxone and overdose response. One more thing I'll mention here is that overdose prevention, planning, and education and naloxone access needs to be integrated in our programming at every level. And it needs to be provided as early as possible in the service. So we would provide it as part of our intake. And if somebody, walked in and, was asking for an intake and we didn't have time to do an intake in that very moment, we would still offer to take 5-10 minutes and do some overdose prevention. Because again, overdose just keeps climbing, and we very well could be saving a life by taking just a few minutes to do that together, right? So we want to do it as early as possible in that initial contact with somebody. And I've just heard too many tragic stories from service providers who build overdose education into the end of their treatment episode, and then a person overdoses while they're in treatment, or they have an unplanned discharge and they never access that information. So it's very, very critical to have this at the very beginning, and then continue to offer ongoing planning and support around overdose prevention, including ongoing access to naloxone, because, obviously at the beginning of a treatment episode, there's a lot going on, a lot of information is being kind of tossed our way. So we want to make sure that this information sticks. So now I want to share Marcy's story, a success story of one of our participants who we received from through a supportive, collaborative discharge planning, as part of her inpatient treatment. So she came from inpatient treatment to our intensive outpatient setting. And of course, again, this is based on multiple different experiences, and details have been changed so that to protect people's confidentiality. So Marcy called us when she was about halfway through her residential treatment stay after receiving our information from her current treatment provider. And what she shared with us was that she would be finishing her residential treatment in about 2 weeks, and she wanted to know how to get started with our intensive outpatient as soon as she discharged from residential treatment. We asked about, where she would be living, what was her housing situation, to, assess whether that would be a need as part of her discharge planning. And she let us know that she would need housing after she finished her residential treatment, but that she was working on potential access to different recovery homes in the area with her inpatient treatment team. And of course, as an intensive outpatient provider, we want to be aware of that. And we also want to be aware of where that location of that recovery housing is going to be ultimately to make sure that we're still an accessible option for someone. So we coordinated with her and then her inpatient treatment provider. And of course, with written informed consent to release of information, we were able to share records, and we were able to really plan together so that she would have that seamless transition. She was able to move into a recovery home and then attend our intensive outpatient with no gaps in care, including no gaps in her medication-assisted treatment. And something that is true here in the state of Illinois, where I am positioned, is that someone cannot be open to two different levels of care in two different organizations on the same day. The day that she discharges from inpatient treatment, she can't be opened in intensive outpatient treatment. That is a system thing that we need to be aware of, right, as intensive outpatient. So through that collaboration and that collaborative planning, we were able to make a plan where she could be, stable in her recovery home and then come directly the next day for all of her intake paperwork and start services that very next day without any kinds of gaps. So with us, she accessed substance use disorder care, including medication-assisted treatment and recovery support, peer-based recovery support. She accessed mental health care, including psychotropic medication, trauma care, and a women's group. And we also helped her to access permanent supportive housing eventually, which she was qualified for because she was living with a disabling condition. At 12 weeks, she was able to step down from intensive outpatient to outpatient services, and then she was in outpatient services for an additional 6 months. And then during that 6-month period, she got really inspired to pursue her education. And she decided that she wanted to become a substance use counselor and started her classes to earn her certification in alcohol and other drug counseling. So by the time she finished outpatient, she had a strong recovery support network. She had strong recovery-oriented relationships with family, which is incredibly important to her. She was pursuing her education. She had stable and secure housing, and she was able to access ongoing medication-assisted treatment through her primary care provider. After that, she then engaged in another 6 months of aftercare services and became an active member in our alumni community, coming to different alumni events and offering support to people in the program. And when we followed up with her 12 months after completing her treatment, she was maintaining her recovery goals and continuing to pursue her education. So just a difference of night and day. Yes. Yeah, and I see here in the chat, a huge barrier we find is that recovery houses cost money and are quite expensive, and clients in treatment can't afford this. I'm so grateful that you are mentioning this. That is a huge barrier for folks. And so, in the folks that we are working with in this treatment setting were able to access recovery housing that was publicly funded, that was funded, the funds come from the federal level down to the state level and then provided at a state level to support people who do not have the means to afford this for themselves. And so this is something that having the necessary kind of funding for recovery housing is incredibly, incredibly important. So that may be something to advocate for. So bridging the gap, and we're getting really close to our what's it called? Break. So just hang with me a little bit longer, and then we'll be taking our 5-minute break soon. So bridging the gap from inpatient to residential services. Some of the things that we really need to be looking at are first and foremost safety needs. What will it be like to return to their community? Where will they be living? What are the threats to recovery in that natural community, as well as are there any other safety needs? Will they be returning to a place where they're experiencing, for example, domestic or sexual violence? For women in particular, this is too common of an experience. And so really looking at those safety needs holistically. Housing and vocational needs, engagement in that ongoing care, that recovery support network, the family support. What is the quality of that family support? How can we help shore up those natural supports, as well as help people plan when maybe there are different family events that may not be recovery oriented? And then, of course, community reintegration, including cultural resources. Culture is prevention. Culture is treatment. Where trauma breaks meaning, culture makes meaning. And I'd love to hear from you all in the chat. What else is important for discharge planning in a higher level of care? And while y'all put that in the chat, I'll go ahead and name some common challenges in discharge planning. Very naturally, increased anxiety about the end of treatment, difficulty anticipating those post-treatment needs, not having the community resources to link to, interruptions in care. And this is where, as providers, we need to intentionally and systematically reduce administrative discharges from treatment, housing, and other services. And FADA has a lot of great resources on reducing administrative discharge. And then also a common challenge is just the lack of established protocols and training around discharge planning. So, how can organizations support effective discharge planning? And this is something that is more for administrators in organizations. And so if you aren't in a position of administrator within your organization, this is something that you could potentially share with administration or advocate for within your organization. So some things that have been found to help are written discharge planning protocols, standardized discharge planning forms, training for all staff involved in discharge planning, reviewing upcoming discharges and discharge plans in team meetings so that we can, as a team, discuss what else might be available, or I know a resource over here, right? Actively cultivating community resources, the routine review of service records to provide coaching and feedback for staff, routinely reviewing the protocols to improve their effectiveness, and then collecting and analyzing that follow-up data. Where are people at with their recovery goals after they have finished services with us? Who's it working for? Who's it not working for? What are the gaps? And what could we add to really improve these longer-term recovery outcomes? So now we're going to launch our second poll. And so in our second poll, it is select as many options as you would like. So if we could go ahead and launch that poll. All right, here's the poll. Um, so select as many as apply and then be sure to hit submit. And this is really asking what resources would support you in using best practices in discharge planning. This is an opportunity to have input that then can be used for advocating for future educational programs, for building resources. So be sure to let us know. Then we'll give y'all, we know there's a lot of options to read through, so we'll give y'all a little more time to fill this out. Please, please, please share with us what would help. All right, and here we see the results. And please, if there's more things you would add to this list, please, please, please put that in the chat and we can save the chat as well. Yeah, so I'm seeing here, trying to see if I can expand it so I can read the options a little better. Here it is. So just more community resources. We just need more community resources. Absolutely. Low barrier housing. Housing is the foundation of health, recovery, safety, everything. Adding a discharge planner to the team. Yes. Additional team members, right? We just need more people. Yes. Well, thanks so much, folks. So we're going to go ahead and take a 5-minute break. I have 6 minutes past the hour, so let's go ahead and come back at 11:11. All right, thanks so much, everyone. All right, welcome back, folks. I hope you had a good little break there. I want to mention some of the things that people put in the chat from things that would help with using best practices in discharge planning. And so here, I want to be sure to uplift this one. More resources for residential that focus on parents with children who are above toddler age. Yes, absolutely. So now, talking about the continuity of care. Some things that make this really, so there's some different pieces here. There's warm linkages and gradual transitions. There's community-based support, and then there's aftercare resources. And so we talked a fair amount already around the warm linkages and gradual transitions. So I'm going to focus here on some community-based resources that include mutual aid resources, recovery community organizations, family, friends, and other natural supports as the person defines them for themselves, and then community-based providers. So some great resources to check out are, for example, Faces and Voices of Recovery as a resource to identify your local resources. They have some different directories that can be helpful. And here again, just want to restate how important it is to offer the full diversity of resources so that people can really select what works for them. When we're mobilizing the natural support system, something that's helpful here is to offer services that can include any significant social supports, that can assess and respond to any safety issues or needs in the person's natural environment, and can also assess any kind of interpersonal dynamics that may be contributing to the substance use pattern of the person who's in services with us. And being able to assess this helps us then provide services that can help address these dynamics and enhance the family functioning or the social functioning. And then overall supporting those interpersonal skill development and healthy relationships. And then community-based providers, this can be so many different kinds of resources here, depending on what's needed and what's available in the community, such as care coordination, housing, healthcare, mental health care, etc. And then I see here in the chat, the Federation of Families and Youth Move are other natural supports. Yes. And I see sometimes many people in recovery are scared to receive those services as well. Absolutely. It's so important to honor that and to create an environment of open communication where we can talk about that together and what, is there a safety need? Do they want to access it, but they feel, they have certain expectations of it that may or may not be, what they find if they were to try it, but just to foster some open communication around it. Absolutely. And ultimately to honor people's self-determination. So aftercare and higher levels of care. So this is important whether or not the person transitions to a lower level of care. Too often, we end up talking about aftercare as something that happens once all the treatment goals have been met and a person no longer needs treatment. So we want to expand beyond that general definition because then it can sound like aftercare is only relevant in like outpatient settings, for example, when the opposite couldn't be more true. So aftercare can happen in a lot of different settings. So it could be at the site of the treatment provider, it could be in the community, it could be virtual, right? There's a lot of different ways that aftercare can show up. And what's really great about aftercare, on top of supporting ongoing recovery capital and engagement in recovery, it also creates an opportunity for early re-engagement in care if needed, so that folks aren't kind of at a crisis point before they reach out. So we want to be sure to be checking in with folks and then offering services if they're experiencing a need for services again. So I'd love to hear in the chat, what are some of the aftercare services that you offer in your program? And while folks put that in the chat, I'll continue moving forward, and then I'll come back to the chat. So aftercare services, the most common forms include recovery management checkups, which we'll talk about in a little bit, very evidence-based. Tech-based support for folks who have access to technology and like using technology in this way. An alumni community, recovery coaching and peer-based support, which is really care at every point in a recovery journey, not just aftercare, and then recovery support services. Yes, and I'm seeing here in the chat, alumni, support group sessions, intentional self-determined exploration of joy. Oh, I'm doing a joyful happy dance in my chair as I read that. Yes, yes, yes. Providing in-home care, including psychiatric and medication delivery. Yes, home-based services are so important. Peer support follow-ups, a resource directory, multi-system coordination. Yes. 3-month aftercare sessions, check-in, follow-up resources, natural supports, medication management. Oh, y'all are putting such great stuff in the chat. This is wonderful. Groups, individual services, televisits, housing, mental health, supportive groups, etc. Yes, yes, yes. So important. Thanks, folks. So glad to hear that folks are doing this. So recovery checkups. Recovery checkups were born out of the idea that no other kind of chronic condition would we just see somebody once and then send them on their way and never check in to see how they're doing, right? So some of the core elements for recovery management checkups are quarterly check-ins, so about every 3 months at a minimum, and then using motivational enhancement techniques to check in with how folks are doing, provide some personalized feedback, help resolve any ambivalence around substance use to recovery, and then, of course, to re-engage folks in services if they do need services. I often think of what I'm doing when I've provided a recovery management checkup is that I'm offering some support. I'm checking in to see kind of what they're doing, what's going well, and then really offering a lot of affirmation around what's going well. And I think of that as kind of like a little booster shot, right? To kind of enhance some of the ongoing engagement and recovery and maintaining those treatment gains. And then also checking in around any barriers. And that might be barriers to recovery capital. That might be barriers or setbacks in their recovery goals. And then being able to offer relevant resources as they define their own goals. So never, never, never to try to persuade or coerce or, leave someone feeling like judged or any of that, right? And something that's really helpful with this is having motivational interviewing skills. That's really helpful with this particular approach. Then for tech-based support, there are some different web-based resources, many of which we've become familiar with and have really blossomed in this age of virtual everything. So some different resources, and when you look at the slides, these links should be clickable. And then there's also a lot of different free smartphone applications, or I should say smart device applications that have become available. This is just a handful of them. There are many, many more. So the Veterans Administration has a lot of different free tools and apps. There's COVID Coach, which is really all about being able to manage stress and support our own well-being around the time of COVID, all the stress of COVID, right? There's also vet change, and there's some to help improve sleep. I mean, there's just so many different resources for different apps through the VA. There's Sober Tool in the Rooms, which is both a website as well as a free app. And then Sober Grid. So this is Sober Grid also is a way to connect with folks, and they offer a free trial of a peer coaching resource. But that said, it's always better when we can to connect somebody with an ongoing peer support that is in the community and is not going to be dependent on a free trial. And then our tribe, something I'll say about our tribe is that it allows people to create an anonymous profile and then connect for that mutual recovery support. And especially for people who have experienced domestic sexual violence or other forms of interpersonal violence, stalking, things like this. The ability to create an anonymous profile can be incredibly, incredibly important because of the ways that their recovery can often be sabotaged by an unsafe partner or ex-partner, or their recovery information can be used against them to try to threaten things like their job or access to education or even custody of children, or use to discredit them in the courts if they're trying to get like a personal protection order or anything like that. So our tribe can be a great resource in that way. Smiling Mind is a family-friendly mindfulness app, so it's something that can be used with the whole family. And I've also worked with people who experience some anxiety, who even when they weren't using Smiling Mind with their children, felt that it was a lot more soothing than other mindfulness apps. So that's just a little anecdote I'll share there. And then there's Liberate Meditation, which is created by and for people of color. And something that I'll say is that to have a culturally specific resource can make a really big difference for folks. And that Liberate Meditation, there is a pay version and then there is a limited free version. So if folks download it, they'll see, the paid version, which if they're able to and want to, they can certainly pay to have the full version. But if they aren't able to afford it, which we know many times there's so many financial barriers in recovery anyways, if they aren't able to afford it, there is a free version. That's kind of like a limited version. And then I know that they also, at least in the past, I think this is still the case, have offered kind of like some scholarships to the full version as well. So there's some different options there. There's also tech-based support for ongoing recovery where a counselor or peer recovery support specialist can actually communicate with people who are part of the program as well as people who are alumni of the program through apps. So that is something that is definitely available, and some programs have decided to start using, especially if folks who are coming to services with them like using applications as part of their recovery. Then the alumni community, things like offering alumni groups, more than one alumni groups. even better if alumni groups can eventually be alumni-led, right? With just staff supporting them, making sure that there's staff support there if needed, desired, but that it's really a space of mutuality. Recovery celebrations. Oh, I'll say one more thing about the alumni group. Sometimes there is this piece where as people start to experience some recovery gains, there can be some natural anxiety that comes up about the end of the treatment because, while treatment was scary at first, now I'm comfortable with it. Now I have this, I've really connected to this group of people here, and now we're all kind of getting, meeting some of our goals, and then this is going to end, right? And sometimes because of that kind of anticipation around the loss of that support, both of staff and the peer group, there can be a lot of fear that comes up around treatment goals and completing treatment. And so aftercare not only helps in supporting people after they've completed services with us, but it also helps to mitigate some of those anxieties around meeting treatment goals and finishing treatment. And so knowing that, I won't be coming here 3 days a week anymore and going to, being in this group, but I can still come here once a week. All of us can still come here once a week and catch up and meet together, right? Kind of knowing that that's there can really enhance confidence in progress and treatment. And that in general, building that alumni community of, of peer support, of recovery-oriented celebration, of family bonding, it not only supports the ongoing recovery, but when we talk about community reintegration, we need to be cultivating pathways for that, right? And that needs to happen right within our very programs. So the different events that exist, so something I did as a treatment provider is that we would hold recovery celebrations and different kinds of, cultural celebrations. And we would check in with folks if they would feel comfortable having alumni of the program invited as well. And we never had anyone say no, that, people actually kind of craved getting to hear from or meet people who had been through the program. And then we would invite alumni to come back. And it was just so beautiful just to see the relationships made, the different ways that people would affirm one another and encourage one another. People would be spontaneously kind of giving testimony, and just how that community level recovery and connection would just spontaneously occur. And then having alumni family events, events and services that are responsive to the needs and preferences and are culturally relevant. So for example, collaborating with an LGBTQ recovery community organization and supporting recovery-oriented pride events, right? So we want to make sure that we aren't just, drifting towards a one-size-fits-all, and that we're intentionally planning different culturally responsive events as well. And I'd love to hear from all of you. What are some other examples of cultural events and gatherings that can help foster community among alumni of the program, as well as support the alumni community? And I'll give you all a chance to put that in the chat, and then I'll come back to it. And so we can't state enough that healing is relational. Healing happens in relationship, in community, and happens in all the things that build relationship and community, right? Hope, trust, safety, right? All of these pieces. And especially for survivors of trauma, the healing is relational. So recovery coaches are really well positioned to be a consistent source of support as someone moves through treatment and non-treatment spaces. And it's going to really make all of these transitions so much smoother and successful. And also, so in this, I want to be sure to say that for treatment providers who want to employ recovery coaches, peer-based recovery support, I use these terms interchangeably, but for treatment providers who want to employ recovery coaches, it's vital that we effectively nurture and support and supervise recovery coaches as recovery coaches. This is a very special role. And if a treatment provider hasn't accessed appropriate training for effective support and supervision of recovery coaches, what can happen is that there's kind of this default where then recovery coaches are either being made into junior clinicians, and I'm using kind of like quotes here, junior, air quotes, junior clinicians, or we end up kind of putting them in this role as a clinician assistant, and kind of just, doing kind of the side work of clinicians. And neither of these supports the true magic of recovery coaching, and certainly doesn't support the practice of recovery coaching. So we want to be sure not only to include this in our teams and through our collaborations, but also to really support and nurture recovery coaches as recovery coaches. So I'm going to go back to the chat here and see, what folks have put in as some of their alumni community. So community outreach and sponsored community cleanup activities. That's awesome. Group dinners, picnics, movie nights followed by ice cream. Yes, I want to come. I want the movie night and the ice cream. And a phone tree to stay connected with alumni. I love that. I was just, I mentioned earlier we have a winter storm advisory here going on today, and I was just thinking about when we used to use phone trees to let people know if school was closed for, our kids, stuff like that. So, yes, I love that. Phone trees and staying connected. Support groups for dads. Absolutely. And then having alumni to come and talk, having an opportunity for, sharing their story and motivational speaking with inpatient residents. Yes, people crave to hear from people who have been through it, right? We all need that. We all need our recovery role models. And then, of course, recovery support services. And this is just, kind of a very broad general list of what are some of the things that are commonly offered in recovery support services. It's certainly not comprehensive. There can be many more things that are offered that aren't necessarily on this list. And not every recovery community organization may have the ability to offer every single one of these, right? So this is kind of just a general list. And so, recovery support services are really an integral part of supporting long-term recovery. And they aren't just important during aftercare. They really need to be interwoven throughout pre-treatment, outreach, and engagement, as well as throughout any kind of treatment service. Um, and so, this is where I often think about things like housing first, right? That if what someone needs is housing, we start working on housing, whether or not they've met treatment goals. Or work first, that if somebody, financial, economic stability and resources are a huge part of recovery capital. And so if someone is saying, my biggest goal right now and my biggest need right now is vocational support, then we believe them and that's what we offer, right? In conjunction potentially with other things for other needs and goals that they've named. So this is not something that is just a part of aftercare, but is certainly a very important part of aftercare. So here are some Florida-specific resources. Floridians for Recovery and peer networks in Florida. So there are different maps and lists, and then also a warm line. And then I want to take a moment to specifically talk about supporting women in aftercare services. And there's a couple reasons why I want to talk specifically about women. And this is because women have unique experiences and needs of substance use and the effects of substance use, the negative effects, and recovery needs that a lot of times kind of go unrecognized in our treatment systems. And so, because our treatment systems aren't necessarily aware of some of the unique experiences and needs that women encounter, then women tend to experience higher rates of not completing treatment and then have poorer outcomes, so decreased recovery outcomes. So, I want to be sure to include a part about gender responsive aftercare services. So some things that have been really found to be core elements here. Helping to address barriers. Women tend to come to treatment with lower economic resources and more likely to have children in their care, so higher economic need while having lower economic resources. So the resource advocacy here is essential. Also, the flexible scheduling and access to in-home services, including things like teleservices. Women tend to, so the research has found that women tend to be juggling a lot more a lot more responsibilities between family demands, home demands, barriers to income and employment. We know that research has found that women are systematically paid less for the same work, right? That feeds into the economic barriers. So having the flexible scheduling and the in-home services can really help around juggling all of those different needs. Also, something to note with flexible scheduling is that, you know, um, about 1 to 2/3 of women in treatment are currently experiencing domestic violence, or have experienced domestic violence in the past year, but that also means that many times there's ongoing stalking and victimization, even if they've been able to escape the relationship. So flexible scheduling here is incredibly important, as well as home-based services, because a survivor, if they're always where they're supposed to be, if they're, supposed to be at a certain place at a certain time and they're always there, that actually really increases the risk of stalking and of victimization, of being kind of located and found and then victimized. So having that flexible scheduling, being able to, schedule during kind of atypical times, being able to reschedule if needed, and then, maybe not having to leave their home if home is a safe place. Home is not always a safe place, though, in that case, in which case, it just becomes it becomes that much more important to really have person-centered services. And if a person says, no, I really want to come in the office, right? Or no, I really need in-home services, or today I'm calling from my car, right? Rather than kind of jumping to any assumptions around that, having that kind of feelers out for potential, is there a safety issue here, right? There's also been many studies that have found that women have much more better treatment outcomes when they have access to women-only gender-responsive services. And when women have been able to, if women are able to name that they want to meet with a woman counselor, for example, that completion of treatment is much higher and then engagement in aftercare is much higher. Having that case management support, which we talked about, right? The resources being so incredibly important. And this is especially important when there are any concerns related to housing or parenting and children's needs. Peer-based programming has actually been found uniquely important for women. And this was found in some studies that looked at women who experienced, a sense of kind of emotional lack of safety, and women who identified as having more complex problems, that they were much more readily engaged and had better outcomes in peer-based programming. So something to note there, right? And then whenever there are children in person's care, and really this goes beyond children that are mom. I mean, I remember working with women who had children in their care and they were the auntie or the grandma, right? So really kind of moving beyond just the mom role, but for any women, and I would say anyone who has children in their care, being sure that we are coordinating any children's resources and services with the person who is in that caregiving role. And I see a question here. Does women-only services include transgender person or trans identity persons? Yes. So when I say women, that is trans inclusive of anyone. So whether it is cisgender women or transgender women, that is inclusive of all women. On that note, something that I will caution against is that sometimes there is a lumping of women and non-binary services together, and there can be some risk in that. And when I say risk, it may not be as effective because there are unique experiences and issues that women only feel comfortable talking about with women. And then non-binary people also have unique experiences and circumstances that they feel more comfortable only discussing with other non-binary, gender non-conforming, genderqueer people. And that it can be kind of to be lumped together can be another way that there's kind of an invalidation of the non-binary gender identity. So something I wanted to name there since we were on the topic of just transgender specific services. Now, at the end of the day, the most important thing is to be responsive to the people in your program, right? So if there are women who are transgender in your program who say, this is all fine and well, but could we have something that's specifically for trans women? Because there are some things that are coming up for me that just, I don't feel like other people connect with it, or I only feel comfortable talking about with other trans women, then by all means, create that space, right? So we also want to be responsive to people in the program. And then here, do services include family education to increase family support? That can be a really, really important resource across the board. So we want to, whenever possible, whenever the person deems it as desirable and safe to include their family, we want to be offering services to engage family, both because the family is affected by the substance use, right? The family has clinical needs and recovery support needs as well. And also because the family support can be so essential, and there can be sometimes some ineffective family dynamics that are actually kind of contributing to the ongoing substance use rather than offering some recovery-oriented support. So there are so many reasons to engage family support. Again, always with the person's desire, and as they name their family, and as the person names that family to be safe supports for them. And family education can be a great way to start that family supportive engagement. So some common challenges in providing aftercare services: funding and reimbursement. Some of our traditional funding and reimbursement channels don't cover aftercare yet, even though there's so much research showing how cost effective aftercare is. So this is definitely a place for advocacy and creativity if it's not already included in your existing channels of reimbursement. And then geographic service areas. So if we offer residential treatment services, a lot of times people who are completing treatment with us are returning to a different community, and that may not be close to our treatment center. And even in outpatient settings, I know from my experience, people often move to different locations as they were pursuing, new job opportunities or rejoining family. So, or trying to maybe, increase their access to more recovery community, right? There's a lot of reasons why people may choose to move. So this can make it more difficult for people to return in person. We certainly know COVID has made it difficult for people to return in person. Then high caseloads, right? If I'm having a hard time even showing up in a way that is meaningful and consistent for the people who are in the service, then layering on, outreach and engagement and support for people who are no longer actively in the service can feel really overwhelming for staff members. And then also just natural disengagement. And sometimes disengagement can be a good thing, right? Someone is pursuing all these other life pursuits. That's great, right? The point of treatment isn't treatment. The point of treatment is living our lives. So that can be really positive disengagement. But other times there can be disengagement for reasons that aren't so positive. And so we want to be sure that we have the ability to really create that access for people and that people feel comfortable reaching out for help no matter what, right? Sometimes it's easy to feel discouraged or jaded when people kind of return for a service. Like, is what we're doing helpful? Is it actually helping somebody? And while ideally we want people to not need us anymore, whenever somebody returns for a service, in a way that's a success, because what that means is that they felt cared enough for, and they felt that you were trustworthy enough, and they felt the service was helpful enough to still have some hope that they can continue in their recovery journey and meet their goals, and that we can be a part of that recovery journey. So what resources would support your program to offer more aftercare services? And here, we'll be saving the chat. And this can be really important information for knowing, what are the gaps? And while folks put that in the chat, I'll go ahead and I'll offer a couple of the different resources and ideas for what we can do next. So some ideas of how to take some of this information and kind of get started. So we could establish a discharge planning protocol and then train all staff involved in discharge planning. Or if we already have a discharge planning protocol, we could review it, right? Is it actually realistic? Is it actually helpful, right? And are staff actually knowledgeable of it? Does staff feel like they can actually follow the protocol, or does it feel like it's written on paper, but it's not really realistic, right? Begin discharge planning and aftercare planning at intake. Use clinical staffing and supervision to review upcoming discharges and discharge plans. Really, clinical supervision, supportive supervision is the cornerstone of effective services. And so having that be part of the routine of what we do together. Nurturing an environment and resources of peer support and alumni community. Expanding aftercare offerings and follow-up. And this is where it's, the resources can be difficult to support those activities. So look at what is something that you could easily add with the resources you currently have. For example, recovery checkups, checking in with people by phone every 3 months. a lot of times we can build that in. It's just a matter of having kind of the support of the organization to kind of make it as painless as possible for making those phone calls, right? So I already talked about recovery management checkups and then connecting with local recovery community organizations and creating linkage agreements with community resources. And this is really stuff that leadership can take the lead on. And so checking out the chat here, things that would help offer some of these best practices in aftercare. Let's see. More staff. Yes, more staff. Transportation to meetings and basic needs, food, gas, healthcare. Transition coordinators. More supportive groups for all populations and genders. Yes. Better funding. Yes. Better communication between treatment providers for good continuity of care. Donations of financial and logistical contributions. Have easier communication with other resources. Adding peer support specialists to programming, particularly MAT programming. Resources to help folks who are experiencing system involvement with DCF. More resources for families. More community resources for Latin peers. Yes. Better collaboration between providers. Body positive support groups. Yes, yes, yes. And more housing resources. I will say it till the cows come home. Housing is the foundation of health, healing, and safety. Yes, yes, yes. So, one more resource here that can help support both advocating as well as creating organizational protocol around post-treatment planning, which and assertive continuous care, which is another way of that we talk about aftercare. And it comes from the beloved William White. And then some additional resources. So with that, then you have a bunch of different references here. These can be especially helpful if you're trying to build a case for advocating for certain coverage or resources. My contact information, please, please, please feel free to reach out to me. Always happy to be a resource and a support. I want to say thank you to all of you for being here today and also just everything you do every day. Healing is beautiful. Recovery is beautiful. It's possible. Recovery looks a bajillion different ways. And to get to be a part of the journey is such an incredible honor and privilege, and also is such hard work. And so many more resources are needed, right? And we need more. And so thank you for being in the struggle, in the journey, and supporting folks every day. And now we have a little time left over for any questions that folks may still have.
Hey, Gabriela, I'm not seeing anything in the chat on my end. Are you?
I'm not.
Okay. Well, not seeing any further questions, we can go ahead and conclude today's webinar. And thank you, Gabriela, so much for an amazing webinar as usual. It was great and very informative. And I have a couple items of business for everyone before we conclude today's webinar. Please see the chat panel for a link to today's evaluation. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or a statement of credit for this event, please make sure you complete the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license, prefix, and number when you register. After you register or sign in, you will be directed onward to the evaluation. Please make sure you use the same email address you used for registering today's webinar when you log in and set up your profile within FADA's system. This will connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The sender will be messenger@webex.com. Please note the evaluation will close midnight Wednesday, February 24th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile. Thank you for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. Thank you all and have a great rest of your day. And thank you so much, Gabriela, for a wonderful presentation.